name is Rashmi Halker Singh. I'm the online and social media editor of Headache. I'm joined today by Dr. Riche, who's one of the authors of a recent publication entitled Trajectory of Healthcare Resources Among Adults Stopping or Reducing Treatment Frequency of Botulinum Toxin for Chronic Migraine Treatment in Alberta, Canada. Welcome, Dr. Riche. It's so nice to have you here with us today.
Yeah, thank you for having me.
I'm an adult clinician. I take care of a lot of people who have chronic migraine, and we use botulinum toxin quite a bit in our practice. So I was very interested in your work. Uh, Topics of how to initiate treatment, how long to continue treatment, when to discontinue treatment comes up a lot. So I was really interested in the findings that you had and everything as well. First of all, can you just start by giving us a little bit of an overview of your project?
Absolutely, sure. So the project is based in the opportunity we have in my jurisdiction in Alberta, Canada, where on a population level we have access to all health data, and it's a single payer system. So we have an opportunity to understand at a population level what's happening with dispensation or prescribing patterns, what's happening with hospitalization use, and so on and so forth. And so with that, of course, I come from a headache background, pediatric headache nonetheless. This is an adult study, but we wanted to understand what the prescribing patterns were for botulinum toxin. And it is in a jurisdiction where we make, as clinicians, clinical decisions about when to start and stop. And so with that in mind, we wanted to observe in health data retrospectively what people were doing. So the final cohort of individuals who had received multiple doses of botulinum toxin was around 4,500, and among those, some continued use and some stopped use. And what we were able to document was their health resource utilization before and after the index dates, as well as the dispensation of other medications, other migraine-related medications. And the results were kind of interesting, I think.
Tell us about the results. Were you surprised by anything that you found?
Well, no, I mean, we use botulinum toxin as headache physicians for a reason, because it often works, and we see it, right? Demonstrating that in administrative health data is not easy outside of that sort of prospective data collection. It's not easy to show. And so my answer to that is yes and no. The challenge we have with a study like ours is attributing causation, but certainly we observed that those who stopped use after a period of a year, they had reduced health resource utilization, and they had reduced dispensation of other medications. Which again, it's not a proof of causation, but an interpretation of that observation is that there was an efficacy in that during the period of time that they were on the medication, they improved and therefore had reduced use after. And we did try to control for the cost of botulinum toxin in our analysis. So that I think for me as a clinician, that's my interpretation of the results. That is, we observed what we observed clinically is a reduced use. And what was interesting though is that among those who stopped or reduced use, particularly those who reduced use, they resumed what we called sort of protocol compliant use, that is greater than 3 administrations, greater than or equal to 3 administrations a year. And so not everyone who receives benefit continues to derive that benefit. So again, not surprising clinically. It was I think useful to see in the data. I think it would have been well, I'll stop there.
Well, as a clinician, I think this data is helpful and probably will add to my conversations with my patients when I talk about the benefits of possibly initiating treatment,
Right.
because we can talk about potential benefits downstream and what they might be able to expect, a year from now or something like that. And people always want to know about that. They always have questions about that, right? And we do know, well, I feel like there's a truism in headache medicine that treating chronic migraine is important. It can be helpful in
Yes.
reducing headache frequency. It can be helpful in reducing acute medication use, and ultimately can help improve someone's quality of life. And personally, I think your study helps to add data to that statement.
Yeah.
Um, and I think that's how I'll probably use this in my clinical practice. I am curious in terms of like, if there's anything else you think I should be thinking about as I approach my patient care.
No, I think you've got it. I think you've got it right, and it certainly the parallels my interpretation of this. The um, the one thing that sort of came to my mind is this. It was the cost of care, right? And I I just I think, as you said, that those with chronic migraine have a significant degree of disability, and we need to recognize the cost of that disability, and sometimes that gets lost in studies like ours. And so, um, some of the cost related questions that come up with the use of botulinum toxin. Um, I'm not sure we settled all of those. There's a cost to using these medicines, right? And we didn't observe a reduction in cost immediately during use. Um, but the but that cost matters. It's important, and the impact of that cost is a period where there's reduced health resource utilization. So, yeah, I think persons with chronic migraine deserve the care they're getting. They deserve the best care, and it makes a difference.
Well, excellent. Well, thank you so much for taking the time to talk to me today. And we look forward to more work from your group.
Thank you.